Good morning. Welcome back to Open Med School. I am Dr. Andrews, Professor of Medicine and Consultant Neurologist. The last session we have discussed about an approach to arthritis and classified it into, depending upon the pathophysiology, to inflammatory versus non-inflammatory. The characteristics of inflammatory, all the signs of inflammation will be there, and one of the very important features is morning stiffness lasting more than 1 hour. We'll discuss it later. Depending upon the time, you divide into acute, subacute and chronic. Chronic means more than 6 months, more than 3 months. Acute means 6 weeks. 6 weeks to 3 months is the subacute. Depending on the number, you divide into monoarthritis, oligoarthritis and polyarthritis. Poly means more than 4 joints. 2 to 4 is oligoarthritis. So now we'll be discussing one case. So this is a history of a 40-year-old person admitted with a sudden onset of left knee pain with swelling and fever. So there are signs of inflammation. There is pain is there, swelling is there, so it is an inflammatory arthritis. Second is only one joint is affected, so it is a monoarthritis. And the duration, it is acute, so it is an acute inflammatory monoarthritis. What are the important conditions? The most important condition to keep in mind are one, gout, second is septic arthritis. So the septic arthritis and gout are usually very difficult to differentiate unless there is a history of hyperuricemia previously, but in a patient with the gout also they can develop a septic arthritis on the important differential diagnosis. Septic arthritis is a medical emergency. So it is an acute monoarthritis. The diagnostic criteria, if you are suspecting, do a joint aspiration and the cells more than WC more than 50,000 per millimeter cube, or the aspirate shows gram stain positivity or culture showing organism. Gout can present almost similar acute onset, but there is a hyperuricemia history will be there, and negatively birefringent crystals can be seen in the under microscope. That is how you differentiate. Another important condition which imitate gout is the pseudo-gout, otherwise called the calcium pyrophosphate arthritis, sometimes called pseudo-gout. It usually affects the knee joint and the wrist joint, and most often there is associated osteoarthritis. So the crystal-induced arthritis, gout and pseudo-gout and septic arthritis are immediate differential diagnosis. Now we go a little more deeper into gout. Gout is a common type of inflammatory arthritis, monoarthritis. It causes pain and swelling and redness and a grade 3 tenderness. That is, even the patient will not allow you to touch the joint. So that is one of the characteristic feature. It usually happens as flare, which can last for a week or two and then gets better. The flare characteristically affects the picto, metacarpophalangeal joint of the, but this is the classical joint. Any joint in the lower limb can be affected, knee joint, and before the upper limb is affected, the lower limbs are affected. So the podagra or the big toe involvement is the classical one, but the other joints can also be affected. And sometimes you may see the tophaceous gout also. That is, a tophe can be seen. The X-ray in chronic cases will be beneficial. You can make diagnosis. There will be usually erosions and the joint space, a punched out lesion like this, and the joint space is narrowed. Now going to the treatment. The very most important, the initial approach is confirm the diagnosis by clinical history, and if any doubt of septic arthritis is there, you have to do aspiration and go for. So confirming diagnosis is very important. You should identify that there is an acute usually occurs in the afternoon. It goes to a peak within few hours, 4 to 6 hours. It goes to the maximum pain. You have to identify how many joints are affected, which are the joints affected, and whether the patient is on urate lowering treatment. That also should be kept in mind. Underlying diseases like renal disease, the hepatic disease is important because colchicine is contraindicated in such cases, and NSAIDs cannot be given when there is a renal failure. So these are also underlying comorbidities should also be taken care of. The common drug which is given is NSAID if there are no contraindications. We can give, which is the not much difference between various drugs. We can start on naproxen, the diclofenac. Full course of anti-inflammatory drugs are usually started. Again, remember acute kidney injury. So they usually can start on naproxen 500 milligram BD, or other analgesics can also be equally effective. The second drug which is often given is colchicine. Again, remember there are a lot of very narrow therapeutic range for colchicine. You can have interactions with various drugs like clarithromycin. So before starting, you should always check the compatibility. So whenever colchicine is given, you have to check the renal function and hepatic function. If any dysfunction, should not give. So usually you start colchicine 0.6 milligram tablet, 2 tablets stat, followed by 1 tablet after 6 hours. Then we can give 1 tablet once or twice daily depending upon the improvement. And 24 to 48 hours after recovery, then only you should reduce and stop the drug. And in some cases, along with the uric acid agents, you may continue for few months. That is regarding colchicine. If you cannot give colchicine, another drug which is usually given is the steroids. Depending upon the severity, can give orally 40 to 60 milligrams of. So depending upon, you can start 30 to 40 milligram prednisolone, taper over 7 to 10 days. If any suspicion infection is there, it should not be given. Only 1 or 2 joints are affected. Intra-articular injection of triamcinolone can also be given. In severe cases, we may give methylprednisolone 20 mg twice daily, or triamcinolone can also be given parenterally. So steroids are useful when there is a renal failure or contraindications for starting NSAIDs. So usual regimen will be, can start on prednisolone 30 to 40 milligram for 7 days and then taper the medicines. If the patient is not responding to protein therapy, that is intractable cases or severe cases, other modalities of treatment like interleukin-1 inhibitor, anakinra can be given. Adjuvant therapies are also important, like raising the limb, applying ice. It is also useful. Always see the drugs and drug interactions, and diuretics, if possible, should be discontinued. Uric acid agents are not routinely given during flare-up unless patient is on uric acid agents already. In such cases, you may continue it. The next session will be discussing on oligoarthritis. Thank you.